All right, let's delve into the meat of this. Causes and correctives, mobility, stability, technique standpoint. The first one, mobility or range of motion. I'm gonna try to get better at not being so long-winded and having so many different causes. So each time I'm gonna try to highlight the number one, if not two, most common causes of Achilles tendinopathy from a range of motion standpoint and how to correct it. So if you think back to our dude Bill, he came into the clinic, he's got Achilles tendinopathy pain. His was located at the insertion. So we have our test, the functional runner screen test. All the criteria, you'll notice the only test that has a range of motion component is this one, the ankle dorsiflexion. All the other ones are endurance, strength, power, and there's a reason for that. In my opinion, ankle dorsiflexion is the most common culprit of injury when it's lacking. And there's a reason for that we'll delve into more later. But you'll see here, you either get a 0, a 1, or a 2. Normal range of motion is said to be around 4 to 5 inches away from the wall with that test. Our dude got a 0 for the affected side. So we're saying in the other side was a 1, that's still really restricted. But the fact that both are restricted, but there's also that difference side to side, that's gonna come into play later of to stretch or not to stretch. And we'll talk about our guy Bill and for our specific case, but also in general. So that's the big question. Do you stretch or do you not your Achilles? So what do you guys think? What I usually base it off of is these two criteria. The location of the injury, and is it joint versus muscle? So I'm gonna go over a little example here of the different locations and this piece of paper and how compression and tendons, they don't get along. They are arch enemies. They hate each other. So again, to recap, mid-substance is where the tendinopathy is located in the middle part of the Achilles versus insertional, as that tendon goes down and inserts into that bone, that's insertional. Both treated very differently. Bill, he's got insertional. So if you look at this piece of paper that I drew, that's the Achilles tendon. This represents mid-substance. This represents insertional right at that heel. So what's gonna happen is I'm gonna pull down and we're gonna see what happens when I pull down at the mid-substance versus insertional. It doesn't do a whole lot at the mid-substance versus insertional. It was folding, it was compressing. So if we look here, if I'm going into that restriction, if I'm going into dorsiflexion, what's gonna happen right at that insertion of the Achilles? It's gonna wrap around that calcaneus, that bone, and it's gonna compress it. Tendons do not like compression. There's not a great blood supply to your tendons as it is, especially the further away from your heart. So when we're doing this, we're getting this what's called an ischemic response, where we're causing, one, some damage to the tissues, and also there's less blood supply. So if it's insertional versus mid-substance, I'm already thinking if it's insertional, I'm not even really gonna think about stretching at this point. Versus mid-substance, go for it. Especially when there's a limitation side to side. If both sides are about 4 to 5 inches, which is considered normal, do you think that it would be appropriate to stretch just for the sake of stretching? Probably not. Don't stretch something just to stretch. That's why we have testing here, so we can have a baseline, a treatment, and then a retest, so we know what we're doing. It's not just throwing random stuff at and seeing what sticks. If there's no range of motion restriction, I'm not gonna stretch it, my opinion. So again, we've got mid-substance versus insertional. The location is gonna help me to dictate whether I stretch it or not. Again, there's an example of it wrapping around that heel. Insertional, no go, don't even think about it. So let's think back to this. Joint versus muscle. As that knee comes forward, what's happening at the actual ankle? You've got your distal tib fib, the bones of your lower leg, they come down and they form this concave structure. That sits on top of the talus, which is the bone on top of your calcaneus or your heel. So I want you to imagine that as like a saddle on a horse. So what's happening is when we don't have that dorsiflexion range, that saddle is not moving forward on the horse, it's stuck. So when it comes to the lack of that motion, if it's coming from the joint, if it's coming from the saddle, there's some different techniques that we can do to try to improve that. Versus, we think back to the analogy before of the tennis net. This is the muscle, the contractile component. versus the rope part, that's the tendon before it inserts into this being the bone. So I can affect the tension here by loosening up there. Imagine if I take 4 or 5 of these squares and I hold them together, what's that gonna do? That's gonna cause increased tension here. So by releasing that, I'm gonna make some changes at that point. So this is assuming that it's mid-substance. This is assuming that when it comes to stretching, it's not insertional. And I'll show you some other strategies you can do if it is insertional. So how do we know which it is? Well, go back to the test. Remember, to fail the test, the heel comes up. So find the distance where you go, where you can't get your knee to the wall, and where do you feel it? Does it feel like it's coming from the front of the ankle, whether it be pinching or a block? Does it feel down lower in your actual Achilles that's preventing you from going further forward? Or does it feel up higher towards the actual muscle belly? Those 3 are going to give you your example of what is restricted. And then when it comes to getting permission, even if it is insertional, to stretch your Achilles, is if we feel like the restriction is coming from the ankle joint in the front versus the back. Hopefully that's an aha moment for you guys. In summary, we've got 2 things. 1, okay to stretch if it's not insertional. If it's mid-substance, go for it. However, all bets are off if you are doing it and it aggravates your symptoms. So again, it's okay to stretch as long as it does not aggravate your symptoms. So if you're someone that says, hey Matt, I've got insertional Achilles tendinopathy, you probably wouldn't be watching this far in if you did. But if you stretch it and it feels great, good, that's fantastic. But most people, this is for people that are stuck. So I'm gonna go ahead and let this play through, and it's gonna go over different strategies for improving ankle dorsiflexion range of motion. I'm gonna have at the top corner the analogy of, is it coming from the joint, the saddle? Is it coming from the muscle, the net? Or is it coming from the actual Achilles tendon itself? Hope this helps, and I'll see you guys next time when it comes to stability limitations. To improve ankle dorsiflexion range of motion, first we're going to go after the muscle with trigger point release. The only time you should be moving the foam roller is to find a tender spot. Once you find the tender spot, keeping that downward pressure, then you're going to mobilize the muscle by flossing it in and out. A ball can be used for deeper, more localized pressure, smaller surface area. Next, to mobilize the ankle joint, keeping the heel down with that right hand, I'm going to drive my knee forward past my toe and apply a little extra forward momentum. More for repetitions. There's 2 muscles that make up your calf, your gastroc and your soleus. Your gastroc crosses the knee, so your knee needs to be straight, heel down. In order to get your soleus, which does not cross the knee, bend your knee, situate back, knee forward, heel down. Another effective strategy to improve ankle dorsiflexion from the joint standpoint is to capture the talus using the web space of the same side hand in the crease of the ankle. With the other hand, capture the calcaneus or the heel and drive the knee away from midline.